today's moderator, Dr. Vishal Kenia, and all Journal Club members. Very good evening to one and all. I welcome you all to this very unique program of Journal Club, which is very successfully run by Dr. Kenia and his group for last 3 years. We are proud of him. Today's Journal Club involves retinal vein occlusion scenario, and we are going to discuss about one article in the journal. And we are very fortunate to have esteemed panel Dr. Santosh Mahapatra, Dr. Vatsal Parikh, and Dr. Ajay Dudhani today. I am sure today's discussion will lead us to a final conclusion, a fruitful conclusion, and will have evidence medicine practice. That is a preferred practice pattern which we will have so that we can render our good services to our patients. I acknowledge and appreciate the efforts taken by Journal Club members, Dr. Kenia, Dr. Zain, Neeraj, Parul Madam, and others. This activity is the first of its kind in our India, and it is running for last 3 years. So all the best to all the club members for their successful running this project, and all the best to all the PG, Dr. Bhakti Gade, who is going to present the article, journal article today. All the best, and thank you for the opportunity. Thank you very much. Over to Dr. Kenia, please, or Parul Madam.
Yeah, thank you so much, sir, for those kind words. And so it's all because of your.
Yeah, just I want to put one quote to conclude my talk.
Sure, sir.
When you learn a little, you feel you know a lot. But when you learn a lot, you realize you know very little. Thank you very much.
It's a nice quote, sir. Thank you for those kind words. And this has been a joint effort of Maharashtra Ophthalmic Society and Bombay Ophthalmic Association. And we are into the third season. And today we have brought up a very practical topic of anti-VEGFs and retinal vein occlusion. And I've chosen a faculty which is a very experienced faculty. Today, the national faculty is Dr. Santosh Mahapatra, who has been a principal investigator for many anti-VEGF studies, ranibizumab and many other molecules. And he has been academically involved in many papers he has published on the national and international level. He has more than 42 peer-reviewed publications. So, on the other hand, we have Dr. Vatsal Parikh, who is one of the senior most vitreoretinal surgeon in Mumbai. And it'll be a treat to have his say on this topic today. And equally dynamic young Dr. Ajay Dudhani, who is also equally experienced and has been into practice for more than 25 to 30 years into vitreoretinal field. So without further ado, I would ask Dr. Parul to take the session ahead and open the Journal Club meeting for today. Thank you.
Thanks, Vaishal. So I would like to introduce our speaker, who's Dr. Bhakti Gade. She is the JR3 PG from KM Hospital. Our moderators for today's session are Dr. Zain Khatib, who's our local faculty. And we have two moderators from KM Hospital, Dr. Avinash Ingole, who is the head of the Department of Ophthalmology Department, and Dr. Hiteshi Jain, who is the associate professor at KM Hospital. So with this, I would request Dr. Gade to share her screen and present the article.
Yes, ma'am.
Yeah.
Is my screen visible?
Yeah, it's visible.
Good evening, everyone. I'm Dr. Bhakti Gade, a junior resident in SAGS Medical College. Today, we will be reviewing an article titled Long-Term Outcomes in Early versus Limited Response to Anti-VEGF Treatment for Retinal Vein Occlusion. This was published in Ophthalmology Journal in August 2023. The impact factor is 13.7 as of July 2023. Retinal vein occlusions are common retinal vascular disorders, its prevalence being 5.20 in general. To be specific, it is 4.42 for branch retinal vein occlusions and 0.80 for central retinal vein occlusions in the population aged more than 30 years. The common risk factors include hypertension, cardiovascular disease, diabetes, and hyperlipidemia. Coming to the pathogenesis, retinal vein occlusions can occur by two main mechanisms. The first being compression of the vein by the atherosclerotic artery, and the second being the susceptibility of the patient to form a thrombus, mainly by either endothelial cell injury, hypercoagulability, or abnormal blood flow, as is called the Purchase triad. This leads to a decreased blood flow, causing hypoxia, a release in vascular endothelial growth factors, and an increase in the vascular permeability, leading to macular edema. The mainstay of treatment in patients of retinal vascular occlusions with macular edema in today's time is injection anti-VEGF. The aim of this presentation is to define early responders and limited early responders after anti-VEGF injection in retinal vein occlusion patients, to ascertain their outcomes at 24 and 36 months, and to discern if comorbidities affect their outcome. Previous definitions of early responders and limited early responders were based on outcomes at the end of 3 months of initial loading dose period of anti-VEGF injections. Early responders were classified as those with central subfield thickness less than 250 micrometers, and limited early responders were those with central subfield thickness more than 250 micrometers at 3 months, a central subfield thickness reduction less than 10%, and a best visual acuity gain less than 5 ETDRS letters or both at 3 months. For the ease of presentations, I will be referring to as early responders as ERS and limited early responders to as LERS. So the gaps in current literature include that there are no studies more than 1 year to about or related to retinal vein occlusion studies. These studies did not control for any baseline BBA and CST, and while the risk factors for age-related macular degeneration and diabetic macular edema have been identified, the same has not been done for retinal vascular occlusion-related macular edema. So the need of this study is to understand better the predictive values of ERs and LERs using 3-month outcomes with longer follow-ups and to characterize the association between response status and comorbidities. The aim of the study is to first and foremost find out whether early responder eyes continue to respond better than limited early responder eyes over longer periods, and to also identify baseline comorbidities associated with response status. This is a retrospective cohort study, and it included all patients aged more than 18 years with retinal vascular occlusion-related macular edema treated with anti-VEGF injections. It excluded all patients with concurrent maculopathies, other ocular conditions treated by anti-VEGF, previous vitrectomy, trauma in the past 3 years, and pregnancy. So the patients treated with anti-VEGF were classified as limited early responders and early responders. Limited early responders were those with central subfield thickness reduction less than 10% and BBA gain of less than 5 ETDRS letters or both at 3 months. Early responders were all those who were not limited early responders. After categorizing patients as early, their BBA and CST changes over the 24 and 36-month period were compared after treatment. Systemic comorbidities were identified for any association with response. So a total of 138 eyes with retinal vein occlusion and macular edema were included, and those with unreadable scans were excluded, leaving behind a total of 116 patients, which at the end of 3 months, on the basis of CST and BBA change, were classified as early responders and limited early responders. Patients without 24-month visit or OCT scans were excluded, leaving behind 68 early responders and 39 limited early responders at the 24-month period. And patients without 36-month visit or OCT scan were excluded, leaving behind 58 early responders and 33 limited early responders at the end of 36-month period. The statistical analysis included a t-test to compare the means of group, a Levine test to assess variance on homogeneity, a Welch correction In case of variance non-homogeneity, a univariate linear regression to a certain association of response with BVA and CST observed clinically, univariate and multivariable logistic regression to a certain association of comorbidities, and multivariable linear regression for association after controlling baseline. This study received approval from the Cleveland Clinic Foundation Institutional Review Board. All research adhered to the Declaration of Helsinki. All study-related procedures were performed in accordance with good clinical practices. Coming to the results, there were no significant demographic differences between early responders and limited early responders. Coming to the injection data, a loading dose of 3 monthly injection anti-VEGF for the initial 3 months was given. Later, the treatment was individualized on the basis of macular edema. As we can see from these tables, there was no significant differences between early responders and limited early responders in terms of injection patterns at the 24 and 36-month time points in either CRVO or BRVO groups. From this table, we can see that the BVA and CST parameters in early responders were a lot worse as compared to the limited early responders. The early responders had a worse BVA and a higher CST to start with, because of which the differences in LERs and ERs were statistically significant. The authors have claimed to correct and control for the baseline characteristics and present the final results at 24 and 36 months. Therefore, after controlling for differences in baseline BVA and CST, change in BVA was significant for both BRVO and CRVO, whereas CST changes were not significant for both BRVO and CRVO at 24 months. Whereas at 36 months after controlling for the baseline characteristics, the BVA and CST changes were both not significant. After assessing for comorbidities like hypertension, hyperlipidemia, there were no significant association between response status and the recorded comorbidities. To compare with other studies, Bisitkul et al. Actually conducted a similar study on clinical trial data, whereas this study conducts over real-world patients. The outcome time point was 6 and 12 months in Bisitkul et al., whereas this study had outcome time point at 24 and 36 months. The outcome at the end of 12 months were proof that 12-month outcome for ERs were better. 24-month outcome for ERs were better in this study. The parameters used in Bisitkul et al. Were only CST, that is central subfield thickness, whereas in this study they included CST and BVA. Whereas Menke et al. Conducted a similar research on real-world patients like in this study, but their outcome time point was at 12 months, whereas this study has an outcome time point at 24 and 36 months. They did not control for the baseline differences in CST and BVA as they have in this study. Coming to the discussion part of it, after controlling for differences in baseline, only the 12 and 24-month changes in BVA remain significant. At the 36-month time point, the functional and anatomic outcomes were not significantly different between ERs and LERs. This suggests that with longer treatment, the less the ER and LER distinction matters. So what is the study trying to tell us? Early responders remain early responders at 24 and 36 months. There is a need to distinguish between early responders and limited early responders for prognostication, and this holds true for both branch retinal vein and central retinal vein occlusions. Controlling for differences in baseline, BVA and CST showed only BVA improvement at 24 months. Number of injections and intervals don't really matter, and comorbidities are not significant. So to conclude, early responder eyes with vein occlusions have better functional responses to anti-VEGF injections at 24 months compared to LER eyes even after controlling for baseline differences. Early identification of eyes with ERs and LERs in vein occlusions may predict long-term functional prognosis. This has impact on clinical decision-making and helps predict the degree to which visual acuity may improve in response to anti-VEGF injections. There was no significant difference in number of injections or injection intervals, suggesting that differences in outcomes were attributed to inherent patient characteristics. The limitations of the study include that the small sample size limited the analysis of comorbidities and association with response status. This study lacked the statistical power to truly analyze these associations. The retrospective nature of the study and analysis restricts the generalizability to patients at other institutions. Only discrete time points at baseline 3, 12, 24, and 36 months were done. They did not analyze for small fluctuations in between those time points. Coming to the MARI, the methods of this study were well defined, the study period was well defined, and the study design is a retrospective cohort. The assignment is appropriate and matched for baseline parameters. The assigned healthcare professionals were employed to interpret data available. The assessment was accurate and precise and was conducted in a retrospective manner, and the type of injection used was not identified. At the end of 24 months after controlling for baseline differences, only change in BVA, that is best visual acuity, was significant both for branch retinal and central retinal vein occlusions. The central subfield thickness changes were not significant in both the occlusions. The BVA and CST change over 36 months are not significant, seen in both vascular occlusion groups. The interpretation of the results in context is important for prognostication. The type of injection used would change the implications of the findings for clinical practice and future research. Comorbidity assessment requires a larger sample size and discussion of any limitations of the study and potential areas for further investigations. So to extrapolate this study, we can apply results of this into our clinical practice by categorizing patients into limited early responders and early responders. This can also help to decrease injection load and can further be cost effective. This can also decrease the patient visits to the hospitals, and early counseling with respect to prognosis can give the patient a better reality check of their condition. These are my references. Thank you.
Thank you, Dr. Bhakti. So I would say that was a very, very well presented, journal article. You've really, got into the complete core of the article and, managed to show all the tabular data and all very well. So with
Thank you,
me, Avinash sir and Hiteshi madam from KEM Hospital are going to moderate this journal club. We'll just conduct it in a slightly different way today. Before we go to the opinion of all the panelists, we'll take the opinion from Dr. Sunny Sen Gupta sir, who is actually the backbone of our journal club. And, he really helps us not only in the meeting itself, but also, has a big role to play in the planning of these articles. So why we are going to take the statistical part first is because Sunny sir, being a retina surgeon himself, can give his inputs, and at the same time, he can explain some of the confusing stats that they have done. The study is conducted slightly in a different manner. You can just explain to us about what is the meaning of controlling the baseline and does it have a clinical impact. So over to you, Sen Gupta sir.
Thank you, Zain. I hope you are able to hear me, right?
Yes, sir.
Yeah, okay. So I'll share quickly my screen and just the PDF file. Okay, so before we go into the nitty-gritties of what this paper says, let us understand that most patients with CRVO or BRVO come to about 612, 618, and that's about it. They almost never become 6/6. I mean, those who keep needing a lot of injections. So if you look at the limited early response group, the way it is defined and everything else, at baseline, let me go over to the baseline differences. So if you see the early response group actually is quite worse, right? They have 45 letters plus or minus 21. Now that is about 636, 6/60 kind of vision. Whereas the limited early response that they're talking about, they already had far better vision. So this is about 6/18 at baseline, right? And if you look at the macular thickness again, there's about 80 micron difference in the two groups. So now if you look at the way the response is defined, they say at least 10% reduction or 5-letter gain, right? So that is how they're defining. That is well and good clinically, but if somebody is already 6/18, he is going to go to 6/12 at the most, right? So that limited early response, when so this is called the ceiling effect. Ceiling effect is where they're already at a much better level. So there is not much room for them to improve anyway. And when you look at the early responders, they have a good chance of getting that delta effect, isn't it? Because they're already quite bad. So now this is called regression towards the mean. Where if we expect most patients to become 6 by 12, 6 by 18, we expect most patients to be at about 63, 64 letters of vision. So there is a lot of chance for the early responders to respond. Whereas you're getting my point, right? So there is not much chance for these limited early responders to respond at all because they are already there, right? They have better vision and other things. So the way these baseline differences actually just knock out everything away from what we are studying here. That's because so if both the groups had 6 by 60 at baseline, now that is when we are talking, right? That is when we are actually trying and analyzing anything and everything. But unfortunately, at baseline only they are very, very different, and there is not much chance for one to improve, and there is a lot of chance for the other to improve. It's like a journal which has an impact factor of 0.5 can go to 3, but a journal which has an impact factor of 2.7 is going to is going to remain at 3. You're not going to say there's a huge improvement. But then a journal which is poor and then gone to 3, now both have gone to the same level, but then the change is huge in one and not much in the other, right? So these are examples of regression to the mean in one group and the ceiling effect in the other group. Again, so uh, in the abstract, they have not mentioned where this data has come from. Most of the papers in the US either look at large patient registries. For example, there is one called the IRIS. So the IRIS registry is one very large. Otherwise, they use Medicare and Medicaid data, which is coming from the government. Where they are actually documenting everything at every visit. But here they don't tell us anything from where the data is coming, right? So whether the data is actually being recorded well, whether it's being everything is being done well or not, we don't know. And also, is this a consecutive sampling or is it a convenient sampling is something we should understand, especially when we are looking at retrospective studies, right? So this is clearly a convenient sampling, right? That's because whoever had the data, that is the OCT as well as the vision, have been taken. Those who didn't have, they were not called. We didn't make an effort to get them back and all. So people who are doing well may come back to us, and people who are not doing very well may actually go to someone else entirely, right? So this is basically convenience sampling, which again adds a little more bias to the outcomes and the way they are looking at. Now, combining BRVO and CRVO is perhaps not a great idea, as most retina specialists will tell you, because CRVOs behave much worse and BRVOs behave much better, especially when you give a loading dose. Therefore, combining the two, which a lot of these other studies do, I don't think it's a good idea. The CST reduction of 10% from baseline and BVA gain of 5 letters is a very good definition to use even in clinics. I call it the 5 by 10 rule. So 5 letters improvement at least, or 10% reduction from baseline at least should happen to call it improvement, right? So this definition is good from a clinical point of view. That's the 5 by 10 rule. But then from the study point of view, it is hindering because those limited early responders are already very good, like I said, at baseline. Now, this controlling for differences is what they are talking about. So let's think about this for a moment. We are talking about change in vision and change in macular thickness. That is a difference of pre versus post, right? So the change is a function of the baseline, isn't it? You are getting the point, right? So if the change is a function of the baseline, how can you adjust for that baseline for both of these? So when you're talking about change in BCVA as the outcome measure, you can't use baseline BCVA as something that you want to control for. So what we are trying to say is, what if the vision were the same in all these patients? Then is the change, is there a difference between the two groups? Right, but then that can't be done, right? That absolutely cannot be done. You can say, cardiovascular status, you can say smoking, you can say BMI, basal metabolic rate, or something like that. But you actually cannot say one and the other because they are almost the same thing. So using baseline BCVA to control is not okay for this kind of analysis. Then they don't actually give us how many CRVOs and how many BRVOs are there overall. They have given it much later in the tables, but then they should actually give it right in the when they are uh, talking in the abstract. Here in the statistical analysis they talk about univariate linear regression. So that is used when the outcome is a continuous variable like this vision and other things, right? So it takes a little bit of explaining to do, but you can actually read it. Uh, remember that we are talking about patients who are at a mean of 73 years. Right? So it's far older patients compared to what we see in our clinics, where a lot of our patients are 55, early 50s, 60s. Right? So these are far older patients. Again, a little bit of difference in what we see. They don't tell us which anti-VEGF at all, right? I think the presenter also talked, Bhakti also talked about where there will be implications. We talk about switching over from one to the other. When that 5%, the 10% reduction has not happened and vision has not improved enough, we want to switch over from one to the other. We just don't want to keep injecting the same drug over and over again, right? Like donkeys, like not looking here and there and just doing that same thing over and over again. So there's bound to be a switch in some patients and not a switch in others. So then which anti-VEGF is really important? And when they switched over a 24 to 36-month period, there is likely a lot of patients who switched from one to the other drug, but they don't give us any information about that at all. Now, if you look at the interval between injections, it's 11.23 and 11.7 in the two groups. Interval of at 24 months, it is 11 and 17 injections. That's about every 3 months, and this is once every 4 months in the limited early responders. At 36 months, if you see, that is ulta. That's about every 10 weeks injections. That's 2.5 months in the limited early responders. So then somewhere here that this thing has increased. That is 19 weeks, and limited early responders is at every 10 weeks. So before they were giving every 17 weeks, and now they're giving every 10 weeks. Suddenly, you have started to give more injections, and why that may be so, we are not sure. So then that again doesn't fit somewhere into the whole thing. And lastly, I wanted to basically talk you through what is meant by outliers, and that there are a lot of outliers in this entire study, making it again very difficult to interpret. So, what we're looking at is mean and standard deviations. So when the standard deviation is large, it's quite large, or it is more than half the mean, that means there is too much deviation on either side, right? So if you see here, the injection interval, it is 19 plus or minus 42, right? It's very large. The standard deviation is very, very large. So that means there are some patients who have gotten injections every 50 weeks. I mean, I'm not able to understand, what they're really trying to say here. Again, if you see vision at baseline, this is 45 plus or minus 21, right? So then again, so 21 is nearly half of that 45. So there's a lot of variability at baseline as well, right? Now, if you see here the change compared with baseline, the change is 19 plus or minus 20 letters. And the standard deviation is more than the mean or equal to the mean. Right? So there's a lot of deviation. It is not really standard. There's a lot of deviation, and that really means that there are some people who have, have a very large change, like 30 letter, 35 letter change, and then there are some who have like 2 letters or 3 letter change, right? So there's a lot of variability here, and that really shows that these are called outliers. So there's a lot of outliers everywhere, and here it is -2 plus or minus 20 again, right? This is like almost, this is almost no change, and this is 20 letter change, right? So there's a lot of outliers somewhere there. Again, so when they say 221 micron drop and 90 micron drop, they say this p value is 0.01. But then later on, they go to say, however, at 24 months, CST change was not significant. So again, it's a little bit difficult to understand. Perhaps these additional tables might have shed some more light here. Finally, if you see at 36 weeks, both are at 64 letters. That's about 618, 612 vision. And so this limited early responders, finally, take home messages, the limited early responders is not really limited, right? They actually have shown response, but they are already very good at baseline. So there's not much space for them to improve. Whereas the others are very bad, and it's a good sign that they have all improved. But so, the way the entire thing has been structured is actually knocked out because those baseline characteristics are hugely different. It would have been great to see, 6 by 68 baseline for both. And then one group has responded only to 636 and the other has actually responded to 612. Now, did those 636 and poor respond catch up later on or not? Yes, that is what we really wanting to study. But unfortunately, this study doesn't, give us any answers to any of that. So, these are few of the things that I thought I'll share.
Thank you, Sen Gupta sir. That was very insightful. If we'll come back to you later, a little bit on statistics, but for now, we'll just pick the comments of our esteemed panelists on the article, and we'll start with Dr. Santosh sir.
Good evening,
Good evening, sir.
So already a nice presentation followed by discussion by Dr. Sengupta. Actually, I agree with all the points what Dr. Sunny has told. Like in my opinion, there is no subgroup analysis in BR view and CR view because they are entirely two different spectrum of diseases where BR view responds very well and CR view has many systemic associations and responds poorly. And the systemic parameters before injections are not very clearly mentioned in the study, apart from just a comorbidity analysis. And in that also, they themselves have mentioned that there are very few patients in each group. And the limitations already, the authors have outlined so many limitations, which include small sample size and which significantly limited the comorbidity analysis. And also they have a single center study. The study was retrospective in nature, and the difference is not so much at 36 weeks. So considering all these, and we usually discuss that you have to study in between the lines, but here in this case, if you study the lines also, they practically differ many times, as Dr. Sengupta was pointing out. So basically, for clinical practice, I think this study does not provide so much which we can take home and practice as for the study conclusions.
Thank you, sir. We'll come back to the questions later. Now I invite Dr. Vatsal Parikh, sir, to give his opinion on the study.
I think Dr. Sengupta and Dr. Mahapatra both have correctly brought the points. It's like, you compare two groups of cataract for visual acuity post-op. One is a brown cataract, another is 6/9 vision to start with. And you say that brown cataract improved a lot. Means ideally, what Dr. Sengupta rightly pointed is that suppose baseline vision is 660 and baseline OCT thickness is 500, then early responder should be one who improved from 660 to 618 or something. And late responder should be one who improved from 660 to 636 or something, or improvement in OCT thickness is less than 10% or something. Because here, other group probably has patients with good visual acuity. So it's not an ideal match, but probably what logically one can derive is that patients who improve drastically in macular thickness or visual acuity are likely to be responding to the VEGF, whatever you injected, and obviously they would do better. But again, as he rightly said, switching over VEGF and what VEGF, anti-VEGF agent you are using is important because nowadays there is a lot of available anti-VEGF like Eylea or Peganex or Vabysmo. So I think these are important points to be considered when you want to make one prospective study. For retrospective study, it may be okay, but for making a meaningful prospective studies, what Sengupta sir has said makes more sense to incorporate. That's all.
Thank you, sir. Over to Ajay Dudani, sir, for his comments, and then we'll have a panel discussion.
So I am not very negative in my thought processes and criticizing a paper. I think we should look at the positive things which the paper has to say. They have done an excellent study, I feel. A 3-year follow-up is very rare in these two RVOs. We have a lot of data in diabetes, but this shows to prove that even RVOs are not as benign as we look at it. We treat BRVOs as a very benign condition, but I've seen in my practice, and as this paper is also showing, we require a follow-up of these patients for almost 2 to 3 years to know the real baseline and get the final excellent vision they have shown in their patients. So I think the point to take home is that these diseases require multiple injections. It's not a 3-injection disease like how we feel like, most of we treat in our patients, because see, in India, the cost is the problem. So this is trying to show you that these anti-VEGFs can modify the disease and, improve the prognosis in these patients.
Sir, you are on mute. Ajay, sir, you are on mute.
Yeah. So in our perspective in India, I would like to lay lay stress on one point is that we have to combine this therapy with laser, which I constantly do in all my patients to reduce the need for anti-VEGF injections, because our patients can't afford these injections for so long. You saw the average number of injections was very high in all the subsets. And switching between anti-VEGF was discussed by all of the other panelists, but I think switching to Ozurdex also is a very strong thing after you have given a lot of anti-VEGF and lasers in these patients, and you have exhausted the VEGF sink in the vitreous. They have a multiple other modulators which are working in these patients, like IL-6, IL-12, and the other modulators besides VEGF. So overall, I think it was a very good study which showed us that this disease also requires a long-term therapy. And like diabetic retinopathy, how we have seen like diabetic macular edema, 3 years is the basic time in which this disease can be treated and cured to a certain extent, unlike AMD, which is a lifelong disease. Thank you very much for listening to me. Thank you.
Ajay, I want to ask you something. Is that this study had a lot of number of the injections were very high. So in your clinical practice, do you also use so many injections over a period of 3 years, or you think of switching it and
Yeah. So as I said in my very first remarks is that they have given like an excellent number of injections, which has given very good results, which we cannot in real life data, especially in our country, reproduce that same. Because we have seen how the patients drop out of injections because we don't have such a robust, you can say, either the financial status or the the insurance which is there in these patients. So that's what I want to bring out, a point which the other panelists can also give me a
Yes,
shed
yes,
light on it.
agree.
You have to combine with laser. You can't retire your laser so soon. Laser combined with a limited anti-VEGF gives you the best results in these patients, which reduces the number of injections. Switch is another thing, but I think you have to lay stress that laser has not to be necessarily retired in your practice. At least is what I feel in the Indian context. If you
I
can
agree.
afford these injections, definitely if you don't ablate retina, it's a better thing. But you saw the number of injections; it's enormous. The load. Yeah.
Dr. Vatsal, sir, your opinion?
Basically, I think the first study on branch retinal vein occlusion, what we call BVOS, is studied for 2 years, And if you try to understand the pathology of the branch retinal vein occlusion, it's the thrombosis which causes the vein occlusion. And then that thrombus gets recanalized. Now, when the thrombus is fully recanalized, then the circulation restores. That's why in old BRVO, you get dilated collaterals along the horizontal raphe. Now,
Right.
what happens is that when the collaterals are forming, if there is a lot of hyperdynamic flow, so there is macular edema, and that is where anti-VEGF plays a role. Now, as the circulation restores or thrombus is recanalized, if there is no damage to the macular capillaries, then the edema would not remain. So this patient may require only limited treatment for 3 months, 6 months, 9 months, and then the edema would subside. But majority of patients will have chronic macular edema. So there we used to do grid laser, but nowadays I don't think we do grid laser. The treatment we follow is after a year of anti-VEGF injections or after a year of the disease process, we switch over to Ozurdex or something, because as Ajay said, this is more of inflammatory response. And eventually, majority of patients stabilize with some macular edema in 612, 618 vision. You give injection, they subside. But again, to come back, but if you don't give injection, I've followed many of these patients, they remain at 612, 69 or 618. And that is what happens in long run.
Thank you. Yeah, over to you, Dr. Hiteshi and Dr. Zain. Yeah.
Yeah, Dr. Avinash and Dr. Hiteshi, you all can just ask the panelists
Yeah.
questions.
I just wanted to ask Dr. Vatsal bhai, when would you use a laser augmentation in the cases? So you are a proponent where you would sparingly use laser?
No, see, I would not use laser for macular edema because we have done patients with grid laser and I've found no difference. So grid laser for macular edema, I would not do. And again, doing PRP, we have this ultra wide field FFA machine. But again, there is no definite proof that if you do based on ultra wide field FFA angiography to ischemic areas laser, that would reduce macular edema, because people have tried a lot of combination. But again, I'm not sure whether it is a sure shot, So it's individual experience and bias, but I would not do laser much unless there is neovascularization or likely to go for neovascularization.
Dr.
Santosh sir,
Mahapatra.
what is your opinion? Santosh
Yes.
sir,
Yeah. See, as for clinical practice, as Dr. Budani was telling, lasers, but lasers not to the macular edema, and I agree with Dr. Parik. You can do sector PRP to the ischemic areas if you are finding extensive areas of ischemia or neovascularization. You do a sectoral PRP, and for macular edema, either you can go on injecting the same or switch over to other anti-VEGFs or Ozurdex as they have suggested. But as we are discussing this article, which tells us in conclusion that yes, there are early identification of early responders or limited early responders in both BRVO and CRVO may predict long-term functional prognosis. We are discussing that. So definitely these are two different areas. Clinical practice in India is definitely different from what the study is telling.
So
Yeah, Dr.
I would like
Avinash.
to, sorry, I would like to ask this panelists a question, if that's okay. This study says that for the initial 3 months, they have used a loading dose protocol in patients of RVO. How many of us actually do that in our clinical practice? Like a loading dose plus a PRN. We always follow a PRN usually, or we go ahead with the loading dose also?
For RVOs, I don't think we go for the loading doses.
Yeah, so this study, the authors have done this in the study, and then they have done a retrospective analysis. So that means they have 138 patients on whom they did a loading dose protocol first and followed up with the PRN. And they have such a large cohort to analyze retrospectively. It looked a little weird to me. What is your opinion, sir?
Yes, same. Because if it is a clinical practice, they might have, if there is a clinical practice there in that center, they might have this number of patients which they could analyze. Otherwise, it is difficult to get such a large number for retrospective analysis.
Yes.
I think United States, it's all Medicare or something, so in here, we don't need that. So we would give 1 or 2 injections and observe. And PRN.
Right.
Jay, sir?
I feel, that loading dose concept is definitely valid, especially in the patients with an ischemic BRVO or a CRVO. If they have extensive hemorrhages, it's like it's a blood and thunder fundus in a patient with CRVO, and it's ischemic with a lot of cotton wool spots, you require more of anti-VEGF suppression, and definitely you will give 3 injections. Even in an ischemic BRVO, I definitely do a 3 loading doses, So it's as was discussed by the panelists, I think you have to go on the clinical picture. And if it's like not responding and there are still a lot of hemorrhages, you definitely have more of VEGF to suppress,
Okay.
So, can I add a few points?
Yes, sir, please.
See, first and foremost, without loading doses, retinal disease cannot be treated like we want them to be. Whether it be BRVO, whether it be DME, whether it be AMD, without monthly for 3 months, nothing we can treat. The disease does not go away, So I'll show you examples of patients, BRVO or DME or whatever. So, baseline is the same 636 and 500 microns or something. Or maybe let me quickly try and pull out one. Yeah. So I'll just show one example. So this is, you're able to see my slide, right? So this is somebody who has BRVO, and you can see this is the, the infrared image, and this BRVO, and this is the image. And at 1 month, this is how it was. This is typically how BRVO responds. So this is the baseline. If you can see this heat map, you may not be able to see these images, but this is 709 microns, and this is how the edema was. And this is at 1 month. There is some edema still. The central thickness looks immaculate. This is 6/12 parts. Central, this scan looks immaculate. If you were just to see this, you would say, oh, everything is fine and perfect. But this red tree also clearly shows, and so does the heat map, that it has not gone away. So if we, ask a show of hands, how many would inject at this time point when the OCT looks like this? 90% would not put their hand up. But then you're missing the bus, because this is just going to never go away. You're just going to keep having edema again and again, and fluctuations are never good. So you need to inject at this point as well, which unfortunately most of us don't do. And then this is at 3 months. There is still edema. and this individual has still required 9 injections overall over a 2-year period, right? So so this is basically, he started from, if you can see the date here, this is about May of 2023. So he got started getting injections from March 2023, and so this is, we are talking about 15 months. He has already got 9 injections, right? So this loading dose concept is, I think, extremely important, and without loading doses, we cannot get great results. And believe me when I say that if you are not doing loading doses and patient is saying I'm fine, then they are going somewhere else, because these diseases just cannot be controlled. Without a loading dose, we cannot get away. After the 3 loading doses, that is when we start talking about, at 1 month, if you don't see enough response, if you see, that vision has not improved and the macular thickness is the same, most of them will have some basic OCT biomarkers, we call them biomarkers, so they are hyperreflective foci and few other things which I don't want to get into details. We think about switching, but then without a loading dose, it's almost impossible to get proper results. Now, macular laser is not recommended for vein occlusions. It's not recommended. The CBOS study in the beginning clearly showed no response. The BVOS, that is a branch vein occlusion study, showed some response, but then they were actually looking at visual stabilization and not improvement. So macular laser is not, whether we do or not do is entirely different than your experience, but then it is not recommended. Whereas DME, actually all these major landmark clinical trials allow for something called rescue laser. And the large DME trials, that is the protocol T, they are actually 50% patients got laser, rescue laser, to reduce number of injections. So DME, it really works. But in RVO, it doesn't work. RVO is like a huge blast. It stays for about a year, couple of years, and it's gone. But the DME is not like that, and neither is AMD. So, RVO has to be hit the hardest right at the baseline. DME is more forgiving. AMD is also has to be hard hit all the time. So it's really a little bit different. So without a loading dose, it's almost impossible to sort of get good responses. Using macular laser for vein occlusions is not a good idea. At least from also from my own experience, doing a peripheral PRP is perhaps okay if there is a lot of CNP and other things. For DME, by all means, we look at rescue lasers after the loading doses.
Can I add something, Sunny?
Yes, sir.
Yeah. See, for case what you showed, it's a severe case with a lot of hemorrhages. So I think there I would not mind giving 4 injections also instead of 3. But many times we get BRVO with very minimal hemorrhage and macular edema. Another thing I do in my clinical practice is, say, after 2 or 3 injections, I call patients after, if there is no edema, say after 2 injections, there is no edema after a month, then I'll call patient again after 3 weeks. If there is a edema appearing now, that means I know that this has occurred within 6 or 7 weeks. So subsequently, when patient follows up, suppose that edema comes at 8 weeks or 12 weeks, then I know that collateral formation is working or thrombus is getting recanalized. So instead of every month, I would try to see when the edema comes, and that will also give me idea about the progression of the disease process.
Yes, so I would say monthly for 3 months, and then all these are perhaps okay.
Yeah,
but
that's
at
fine.
least monthly for 3 months. If you're doing aflibercept, maybe 2 months. But those initial loading doses is really crucial. Otherwise, it'll just
Even
keep
for
coming
minimal
back.
hemorrhage, then early.
No, that's what. So those are minor BRVs, are like
Yeah.
tributary vein occlusions. For them,
Correct.
yeah, this perhaps we can be a little
Correct.
bit
Yes.
more lenient.
Yes.
So I think the general consensus of all panelists is that a loading dose is a good idea in all indications for anti-VEGFs. Let's discuss a little bit more about this study. So I want to know from the panelists, Santosh sir, I would want to know from you. So here they have classified LERs, as those who at baseline, as Sen Gupta sir said, have less amount of macular edema to start with, and they have good visual acuity. So when we are seeing these patients and counseling these patients for injection, do we not promise them that they will see much better? Because if they start off with 618 and they come back to 612 after so many injections, then they probably may not feel the difference. So from this study, can we interpret something like this, that those who are limited early responders will not have a very dramatic response?
No, already Dr. Sunny has pointed out that when there is a space to jump, you will jump. When there is no space to jump, you cannot. So improvement from 618 to 612 or 69 is very small in comparison to a vision which is 660 and coming to 69 or 612. So there is a big gap there. So in those cases, they will definitely have a wow response. But here, they may not have. So definitely this.
So would it be fair to say that these patients would not be that satisfied after injections, or they would not see much of a
Yes, they may not
benefit?
be. Yes, they may not. Yes.
No, then I think you have to tell them that your vision is already good. You are much luckier that your vision is not so bad, So you don't expect it to be like other eye, but it will be better. Because telling them that way would make it them more happy,
Okay.
Positive. You have to tell them in a positive manner.
You have to tell them that if you don't take injections, it is going to drop. Your vision is absolutely going to drop. So don't wait till it becomes 636 and 660.
Yes.
This is the time to inject, and you will get better, slightly better, because already you are, you're good.
Dr. Sengupta, I had just one question about the study. So when they talked about the data, they said there was some intraretinal fluid on the OCT, subretinal fluid, and there is no fluid. So does it mean that they didn't have macular edema? Or when you see the table, the findings, they have said that some of the patients did not have any fluid.
Yeah, I'm just taking a look at the table.
So why were they injected?
Yeah, so 19 and 8.
Yes.
I'm also not sure why. So without fluid, we don't inject at all. Very rarely, there may be a lot of hemorrhages and there is not enough fluid, but then it's very unlikely that there is no fluid at all.
There could be treat and extend protocol also, no? Sometimes.
Right.
Because if the patient comes sometimes, we treat to extend the next injection sometimes.
So that what we're talking about is baseline, yeah. You're talking about
data.
baseline. Yeah, baseline and no fluid. So that's a little bit of
no fluid.
Yeah, surprise. I'm not really sure what they were doing and how they were doing it, but also, that most people will use some predefined criteria to re-inject, especially at Cleveland Clinic and these large organizations. But here they don't give us anything of what they did to re-inject. They just said it's at the basis, at the discretion of the treating physician, which is great and all. But especially in retrospective studies, we need to understand, right, when they were re-injecting. Because if you're saying, there is a 19-week interval between injections, right? That's what they have given. At 36 weeks, is 19 weeks. That's like 5 months. So then at the third month, patient came with, I didn't re-inject. Why? Oh, I felt it's okay. At fourth month, I felt, oh, it is still okay. At fifth month, I said, oh, now is the time to re-inject. So then that's a little bit of subjectivity also in that. So the re-injection somehow is, though the number of injections are high, but at 15 injections at 3 years, that's a 36 weeks, 15 injections is pretty much par. And we need to explain this to patients that you will need it 7 in the first year, 5 in the second year. That is reality. Whether we actually go ahead and do this is really based on whether you have enough monetary firepower and insurance.
I presume it's an insurance dependent system there.
That's right.
It is easier for them to
So
get.
generally I tell people that this is copybook. This is how it should be. Now you tell what you can afford. Accordingly, we will try and cater it to what you can afford. And then if I say 7 and they say 2, it's like that's not going to work, right? So if I say 7 and they say 5 injections, I can afford 5 but not 7. Maybe I'm still in a win-win, isn't it? I'm still in a win-win because a lot of people do get away with 5 injections or maybe even 4 injections. So it's important to tell them that this is what you will likely need, because this is what most people need. And a lot of people actually, irrespective of how they look like, actually say, okay, fine, that's okay. At least 20-30% will say it's fine. And a lot of the others will say, oh, I'm not able to do these many. So at least loading dose and then we'll see. Right. So that's what I tell them. And therefore, a lot of people do take loading dose. Without a loading dose, starting is no use at all. Without a loading dose, it's not going to work.
Okay. And the question to the panelists, what do we do with the non-responders?
We switch.
Do we see non-responders very often? And if so, how
you have to switch the injection.
Switch the molecule. That's right. Yeah.
Okay,
switch to Ozurdex. Ozurdex usually works in these patients who have, exhausted the VEGFs. If you switch the molecule to a steroid, I've had very good response in these chronic patients.
And do FFA also,
And then laser to the non-perfusion areas. in the periphery.
But people will still need 4 injections, 5 injections of Ozurdex, 4, 5. So that is really how it is. If we want to see it to the end of time for them for their disease, be prepared for 4 Ozurdex, 5 Ozurdex. Ozurdex, the latest Ozurdex leaves behind its skin. I have patients who have 4, 5 skins of Ozurdex in the inferior pars plana. Ozurdex can, with multiple injections, can cause viral retinitis. It can cause raised IOP, as we all know. It can cause cataract. So then somehow Ozurdex doesn't fit into my practice currently when we have brolucizumab
Now you can have Pagenex as well.
yeah. So I don't use Ozurdex almost for the last whole year. I think I've just given it for uveitic CMEs. So I generally switch to if it's ranibizumab, I'll switch to aflibercept. If it's aflibercept, I'll switch to Pagenex or brolucizumab, like that. So brolucizumab
But
also works for 3 months.
but Pagenex in patients with RVOs, when occlusion is a one of the side effects, I strongly don't use Pagenex in any vein occlusions.
No, I don't think that in chance of IOI is more in vein occlusions and less in neovascular AMDs and other things. So, that IOI is going to, if you use enough IOI, if you use enough Pagenex, you will get IOI, irrespective of what disease you're treating. It's like if you do enough cataract surgery, you will see endophthalmitis. But that doesn't mean we stop doing cataract surgeries. Same way, if we use enough of Pagenex or brolucizumab, you will get some kind of IOI, intraocular inflammation on and off.
No, more worried about occlusive vasculitis. I'm not worried about IOI. I was talking about occlusive.
No, that's what. See, it's the brain which is trying to bring the two, phenomenons together. But I don't think they are related. It's easy for us to believe, but then I don't think occlusive vasculitis is more common in vein occlusions. I don't think that is the case.
Okay.
And
Are there any special circumstances in which one might prefer Ozurdex as the first line in a patient that comes to you for the first time, say with a very chronic edema, loss of bridging processes or something like that? Do any of you ever do that in your practice?
Yes. I think
Recent myocardial. Sorry, go ahead, Mahapatraji. Go ahead, please.
No, if you have large sister spaces with hyperreflective foci and presence of SRF also, I think you can definitely consider Ozurdex in first line also.
The patient with recent myocardial infarct or stroke, probably that would be an indication where you would give Ozurdex, first. Suppose he has got an heart attack just 15 days back or a month back, you would definitely want to avoid anti-VEGFs.
So do you avoid all types of anti-VEGFs in such patients?
Legally, yeah. It gets into problem, you are in big soup,
Right.
I had one patient of CRV whom I treated with Ozurdex, and he came back 3 months later with neovascular glaucoma. So I think, using Ozurdex as a first line when there's a lot of VEGF sink in your vitreous is quite dangerous. I think first I would really go in and do a anti-VEGF, suppress the VEGF sink in the vitreous, and then switch.
No, but Ajay, patient has recent infarct, say 15 days back or something like that. So
yeah. Then definitely, sir. Definitely.
Then you have no choice.
Definitely.
Then you have no choice. Either you.
Yeah, but then I think you should follow up that CRVO patient very closely, for developing NVG. That's what.
Correct.
One silly question. I probably don't know whether I'm right or not to ask this question. When you use so many of anti-VEGFs, do you see any associated retinal atrophy or I don't know. So do we have a
endothelial atrophy is common?
Please, Ajay. I know this is a silly question, but
no, not a silly question at all. I'm just joking.
No, it is reported.
Okay.
Specialist.
This is one of the complications reported in long term. Yeah.
So we see more of RP atrophies in neovascular AMD, and that is mostly due to the pathology and the drusen, which is getting that's the natural history. When you have large drusens, you are going to get RP atrophies. So it's not attributed to the anti-VEGFs as such.
Okay.
So this is a concern only in neovascular AMD, where we see enlarging geographic atrophy in patients who are getting a lot of anti-VEGFs. But then, teasing it out and saying that this is because of anti-VEGF and not because of the disease process itself is very difficult. So then, it's not, this RP atrophy is not a concern with RVO and DME, but it is kind of a little bit of a concern with neovascular AMD.
Okay.
Sen Gupta sir, just in the end, related to the study, there was a regression analysis done where they did not find any correlation of any risk factor with these outcomes. So, just a word on that. Would that be because of the small sample size, or actually there may not have been a relation? And these risk factors actually are known to be there, right, with the response outcome.
And so they present one table, right? That table 5, which is a they call it, yeah, they call it logistic regression analysis. And if you see the whether I can pull it up quickly, and it'll be easier to understand. Just one second. Yes. So this is the table you are talking. One second. So this is the table you're talking about, isn't it?
Yes.
So these are odds ratios. As soon as you see odds ratios, first and foremost, understand that we are talking about an outcome which is a binary outcome, yes, no. So here the outcome is LER, right? LER is limited early response. It's yes, no. Right. So first and foremost, when you are looking at factors which are predictive of limited early response, these are all the factors that have been studied, right? The systolic blood pressure, hypertension, hyperlipidemia, all of these. They are also yes, no kind of. That's how they have recorded these. So it first and foremost it depends upon the number of events that are there. So this is events means here it is limited early response, right? So that's about 38 events in at 5 years. So we need to have at least we have to have relatively larger number of events for us to say that this is reliable. So here the number of events is very small. Overall, the sample is less than 100. Out of that, about 38 or 39 have limited early response. Right. So we are really comparing 60 with 40. For a regression, the real question is when you compare so many, the real question being asked is what if all were the same amount of smokers? What if plus they had same systolic BP, they had same hypertension status, they had same hyperlipidemia, they had same of all these, they had same HbA1c levels and all. After this, is this limited early response more common in one group than the other? Right. So you're already using, you only have about 38, 39 events. Right. Now, in that you can maybe study one effect of one or two factors like smoker or maybe say BMI or something like that. So the number of events is very important. So odds ratio, if you see these numbers, it's like 1.100 or whatever. So it's like 1.1 million times. So the chance of LER is 1.1 million times higher if you are a smoker compared to if you're not a smoker. And that varies from, the 0.47 means this is 53% lower chance. And this is 2.59 million times higher chance. P is not significant, but this is huge. This is such a huge number is because the number of events is very small. Again, this peripheral artery disease is 2.2 million times higher to get limited early response. How can that be not significant, right? See, again, they clearly say here cannot define due to very small samples. Right. So, excuse me. Actually, this entire table is useless. They should have actually given some of the tables which they say are, like table 2, 3, and 4. So this is table 4, which is actually, vision and other things at different levels. And this is table 3, which is actually BCV, and table 4, which is actually OCT thickness at different time points. How can you not give this in the main manuscript? How can you say this is a supplementary material, right? And that unless you are having something to hide there. So then, I was trying to find these, supplementary materials, but I actually couldn't. But then, so this when you are looking at odds ratio, say a very good example of using odds ratios would be risk factors for endophthalmitis. There is a very large study from Arvind which has looked at 6 million surgeries, and they have said, there's some 2,000 endophthalms and this and that. Now that is a study where we actually can say there is a huge number of events, isn't it? And the overall sample is very large. So that is where a regression analysis is very good, where you say, if a resident is doing surgery, the chance of end-off is 4 times higher or something like that. That study does not do regression analysis. That kind of study, imagine, does not give any odds ratios at all. Then, what are we doing? It's like, we really don't know what we're analyzing. So this kind of study should not present regression analysis and odds ratios. When you have a sample size which is less than 100 and you have the number of events which is like 30 or 40 or something like that, you can't do odds ratios. Unfortunately, almost all studies which are published in these large journals will have regression analysis. But then 90% of them are all bekar.
Got it. So we have crossed the time. Vaishal sir, over to you.
So it was an interesting study and study about retinal vein occlusions, and we had a very good opinion of all the panelists on the anti-VEGFs and how do they manage their retinal vein occlusions. So I thank Dr. Santosh Mahapatra, Dr. Vatsal Parikh, Dr. Ajay Dudhani for contributing to our journal club meeting. And I thank Dr. Avinash Hingole and Dr. Hiteshi Jain and Bhakti. You did a marvelous presentation. I thank you on that.
Thank you,
And
sir.
really grateful for the postgraduates teaching institutes to participate in this journal club meeting. So
Thank you, sir.
and the other thing is, without my team of Dr. Parul Deshpande, Dr. Zain Khatib, Neeraj Israni, and Dr. Sunny Sen Gupta, who's our star statistician, the way he puts up and analyzes and makes, definitely it's very insightful and adds value to our journal club. So this journal club team has also been very robust for these last 3 years. I thank them. And I thank the BOA and the MOS executive members for giving us this opportunity to showcase this journal club meeting. And we'll be back again after 2 months again with yet another topic, interesting topic and interesting faculty again. And last but not the least, I thank Entod for supporting this Zoom meeting. Anyone else whom I'm forgetting, Zen, to thank?
Our panelists.
No, sir. I think we've taken everyone's name. Neeraj couldn't join today because he had a emergency, but he's the one responsible for coordinating with the government institutes to get the postgraduates and the professors on board. So,
True.
Thank
So-
you, Vaishal.
So thank you, everyone. And it was a very contributing and insightful meeting today. Thank you so much.
Thank you.
Excellent,
you,
Nadu.
everyone.
Thank you.
thank you.
Thank you.
Good night, everyone.
Thank you, everyone. Good night. Good night.
Thank you.